ఉంది సార్, ఫ్లైర్లో ఉంది.
ఒక్క నిమిషం.
చేసావా? గోలైవా? రెడీ సార్.
Welcome to you all from Asian Institute of Gastroenterology, the Hepatology Department. Today is a very important day. Today is a World Hepatitis Day. On this occasion, we have a panel discussion with our experts. And our experts are Dr. Sadhana from Microbiology, and Dr. Anand Kulkarni, and Dr. Shantan, Dr. Mansa Allah, and these are the experts which are going to answer some of the questions which we normally would like to know. The first thing is, let us see what is this Hepatitis Day about, and we know that, we are performing many days, the Parents' Day, Children's Day, like that, even in the health section also, we know that why there are certain days are there, like a World Liver Day, World Fatty Day. So in the sense that today, 28th July, has been considered as a World Hepatitis Day. Let's see what is this World Hepatitis Day about. And one scientist, this right, Baruch Blumberg, and he is the person who has first, found out what is this hepatitis B virus about, and that invention has led on to vaccine preparation. Not only that, the medicines for hepatitis B, and more importantly, the prevention of hepatocellular carcinoma. And this date, 20th July, was chosen because it's the birthday of the Nobel Prize winning scientist, which I have told you, Dr. Baruch Blumberg, who has discovered this hepatitis B virus and developed a diagnostic test, which we have been doing it regularly as a HBsAg, and also which has led on to the vaccine for the virus. Not now, quite long ago, Professor Baruch Blumberg has mentioned, and you can see the importance of a health importance, public health importance of this sentence. Only a small fraction of those who could benefit from antiviral therapy are being treated. World Hepatitis Day, why we are conducting this day is that this day can make a public and the governments aware of what can be done and the potential of a great improvements in the health all over the world. And this what his message on that day. and understandably, this stands very true even today. Each year, more than 1 million people lose their lives to hepatitis, and the number of death is rising. But why? Why it should happen? You can see that we have a very fast and then accurate test, and many people many labs are doing routinely these hepatitis. The panel of virus tests are done, not only hepatitis B, hepatitis A, hepatitis E, they are also being done. And we got a very effective, affordable treatment. Of course, as of now, it is a mostly lifelong treatment. And we have got a vaccine which has got a proven efficacy in 95% of the newborns from getting the hepatitis B. If you have so many good points, how is that why we are not able to conquer this particular virus? It is because low awareness, people do not know. And the studies conducted across the world, many people did not know what is a hepatitis B, and when they do not know what is a hepatitis B, obviously they will not be knowing about the vaccine, and then they will not take the vaccine. And misinformation, and that vaccine may not be helpful, or hepatitis B, we got a lot of a social stigma is attached to hepatitis B, and therefore somebody may not even get tested for that one, lest they will be tested positive. And there have been many of the myths and stigmas are there, and these are the ones which are stopping the people from accessing to the hepatitis services, and this ultimately leading to lack of action by the decision makers. Lack of action, not the intention. Intention is there for all government to curb the virus and to see that the hepatitis B mukt world, that's what is ultimately the essence. But unless the person knows about it, he won't come to the hospital. And these are some of the drawbacks, in the society as a whole. So then what are the facts which we have to know is that it's the world's one of the viruses of the COVID. It is one of the important viruses which can lead on to even hepatocellular carcinoma. And so many people are suffering across, as you can see here. And it is the leading cause for the liver cancer. And we have everything we have to do. We need to eliminate the virus. That is the WHO's this one slogan is that we have to eliminate by 2030. But the world is moving backwards. Then somehow we are not able to make a progress because of some of the obstacles which I have already told you about that one. And what is the slogan for this year? Each year, we have got a slogan on the World Hepatitis Day. And that for today, for this year, it is called the Let's Break It Down. And the slogan is another is that getting vaccinated for hepatitis B also protects against the liver cancer, and therefore we have to get the facts and we have to get vaccinated. Of course, we got a long ago, we have rolled out the National Viral Hepatitis Control Program, and it has been incorporated into the Child Immunization Program compulsorily. The hepatitis B vaccination is a compulsory now. And we have a Indian National Association for Study of the Liver Diseases also have given very broad guidelines about the diagnosis, management and prevention of hepatitis B. We have of course certain lacunae that the low awareness is still a major problem even in our country. And with this, I will hold on here and let's go on to the panel discussion here. And we have a Dr. Sadhana, who is a microbiologist. Sadhana, can you tell, because many of the people, they will not be able to differentiate between a virus and a bacteria. The many people, they were aware of the virus very clearly, is because they say that it's gone to viral, that's a different. And during the COVID time, many people have become aware about that one. So what is this virus about? Can you?
Yes, yeah. We have lot of microorganisms. Everybody knows about bacteria, and of course because of COVID, also know about the virus. And we have lot of other parasites, fungi and all that so on. So virus is a very small.
Slides, madam.
Virus is a very small particle. It is about 10 to 100 times smaller than the bacteria. Yeah. So in essence, it consists of basically only the genetic information in a carrying case, a protective coating called as the capsid. So it is a very simple structure. So they are not made up of cells. So they don't have all the equipment to make copies of themselves or even to convert food into energy, metabolism. Instead, they carry only the instructions with them and then use the host cell equipment to make more copies of the virus and also to survive. So this is like a gray area whether you call them living or non-living things. Next slide.
Next slide, please.
Right, so there was another slide. I think the differences between bacteria and viruses you wanted me to say. The bacteria are complete cells and they can divide on their own and also reproduce, and they have all the mechanism for the metabolism to make their food and everything. Whereas, as I said, the viruses don't have, they always need a host. This is about hepatitis B virus. So that is a simple structure. Basically, it has a surface layer along with a lipid membrane, and it contains all these surface antigen, which is what we detect by testing in the lab. So there are 3 different particles in that, so large, small and medium. And then you have a core antigen, right? And then we also have an E antigen. And then there is the DNA and the DNA polymerase. So that is the structure of hepatitis B virus. Yeah, maybe. So we have markers for hepatitis B. Now, how do we diagnose? So this infection produces a lot of antigens and antibodies which will follow a distinct and individual serological patterns. So depending upon the stage of the disease, they appear in the serum and also disappear. So by monitoring these markers, it is possible not only to diagnose but also to determine the stage of disease and also the probable prognosis. Let's look at what are the markers. The next slide. Yeah. So basically, the hepatitis B surface antigen, that is the main test that we do for screening and surgical profile and all those things. That is the one where the surface antigen is detected in the serum. And then you have anti-HPC, that is antibodies to the surface antigen, which are actually protective antibodies, and when you are vaccinated, you develop these antibodies. And you also have a core total and core IgM antibodies. You have also E antigen, which can be detected in the blood. When that is detected, the patient is highly infectious. And then you also have the antibody to E antigen, and then we detect the HBV by PCR, the actual virus particle in the blood. Yeah.
Okay, you just keep the slide on, Dr. Mithun, anti-HBS, she said that it's an anti-HBS antibodies are there. What is the importance of that one? Suppose I got an injection. Many people ask, sir, I have taken an injection about nearly 10 years before. Should I test it now? Should I take a booster? What is the level which I am supposed to have for protection?
So anti-HBS, ideally the testing should be done 1 month after you complete the vaccination. So sometimes when you test it after 10 years, the antibody titers may wane. But that is not actually a justification for a revaccination unless and until we know that the titers are actually not attained after 1 month of vaccination. So there is no point in testing at any other point of time. A value greater than 10 is considered to be protective. So there will be memory cells in the body. So even if the titers wane over a period of time, when we get an exposure, the levels of anti-HBS will suddenly shoot up, indicating that the memory cells got activated and our protective antibody is still there.
So how much level is safe?
So 10 is what we consider safe. Many times if it's a healthcare professional, there were values up to the cutoff of 100 was taken to be safe, but anything above 10 is protective.
Okay. Dr. Anand, see, somebody has got a HbSAg positive for a long time, but now he gets an acute jaundice. HbSAg is positive. Do you think that it is because of only HbSAg, or it can be because of something else also? He can get a hepatitis A or hepatitis E through the water infection. How to differentiate?
So whenever a patient with acute jaundice comes, if it's a known hepatitis B, it is usually because of reactivation of the virus. It is usually because of reactivation of the virus. We usually check their viral levels, also check for the AST, ALT, enzyme, liver LFT test. If the patient has history of exposure to foods or anything, then probably we also assess for hepatitis A and D, which is very common in India.
Right. And Dr. Sadhana has told about IgM anti-HBC.
IgM HBC, which will be
So,
done to identify
yes.
acute hepatitis
So,
B.
if HbS, the message is that if HbSAg is positive and somebody has got a jaundice, if look at the IgM anti-HBC, if that is positive, then that means that that jaundice is because of hepatitis B. If that is negative, he is carrying the hepatitis B, but the jaundice may be because of something else. Right, Dr. Anand, when you are there, and what is special about hepatitis B in terms of a public health?
So,
Before that, I would like Dr. Mithun to tell us, what are the hepatitis viruses, which we have, Is it caused only by the hepatitis B?
No, the commonest virus that we all tell our patients are two viruses which are by fecal-oral or waterborne. One is hepatitis A and E, and the other is hepatitis B and C. There are other viruses which can cause jaundice, like cytomegalovirus, Epstein-Barr virus, but these are called second-line viruses, which means we only test them in patients with a high index of clinical suspicion when all the other viruses are negative, and yet we feel that it could be a viral etiology.
Right. Coming back to the hepatitis B virus, what is the importance of public health? What is the magnitude of the problem, particularly in our country also?
I think you also showed in your slides that a slide should be. 9 out of 10 men living with hepatitis B actually don't know that. And in Southeast Asia itself, 97% of men and women living with viral hepatitis don't know this. This is from WHO, which I have taken these lines. And hepatitis B and C kill more people annually than HIV and AIDS, malaria and tuberculosis. And these are the viruses which account for 2/3 of the liver cancer deaths. So hepatitis B is very important to us, and we are the second highest in prevalence of hepatitis B. First is China, and second hepatitis B. We lead the prevalence. This is the NFHS data, National Family Health Survey data, showing that the national seroprevalence of hepatitis B is 0.95%, and seroprevalence is very high in the cities we live in, that is Andhra Pradesh and Telangana, 2.39%, which is followed by northeastern states, which is 1.65%. We have other states which are also around 1%, but our national average comes to around 0.95%. But we are in the belt of very high prevalence of hepatitis B.
Although I think definitely after the vaccination is being done, definitely the incidence is coming up. But there is a lot of heterogeneity in the country itself. Some areas are highly represented, maybe because of a drug use. I think intravenous drug use.
Probably because of IV drug abuse. And there are certain studies showing that Andaman and Nicobar Islands and tribal areas are very high prevalence of hepatitis B, even going up to 20-22%.
I think Dr. Shantan, sometimes they say that incidentally he just went for a routine checkup, and then he was found to have a hepatitis B. Then onwards it started, his anxiety. And then what should I tell him, and what are the consequences, basically what happens?
Right. So whenever a patient is diagnosed with hepatitis B, most of them will be incidental for any surgery or for any medical checkups and everything. So when we see the consequence hepatitis B infection, normally most of the patients will be asymptomatic in the first stage. But gradually with the progression of disease, they can develop hepatitis. Hepatitis is the swelling which is caused in the liver because of the hepatitis B virus damaging the liver tissue, liver cells. Then if it is left alone, this constant damage will change into a fibrosis stage which is called the cirrhosis. Sometimes, irrespective of cirrhosis, there or not, the patient might develop from fibrosis itself to hepatocellular carcinoma. So the patient might develop with incidentally might be detected hepatitis B. On a long run, the patient might develop into hepatocellular carcinoma. Also, this is all liver related, but sometimes hepatitis B infection also can cause extra hepatic damage, such as in kidneys, which can cause glomerulonephritis, and sometimes in the blood vessels also it might cause problems. So overall, if left alone, the patient might be developing both liver and extrahepatic related damages and further progression of the disease.
Apart from cirrhosis apart from the hepatitis B, can any other virus cause the cirrhosis?
Yes, hepatitis C is one of the other leading cause why it can cause cirrhosis.
Right.
So
Okay.
both are mostly transmitted serologically.
What about A and then E?
So A mostly
Do
will
they
be,
cause any chronic infection and then cirrhosis?
yeah, A won't cause chronic, but it can cause a relapsing cases. But E sometimes in immunosuppressed patients, immunocompromised patient can have chronicity.
Ah, that's what. Rarely.
Rarely,
They're not
rarely,
in
very
common.
rarely,
Post-transplant and that kind
Yes,
of a thing.
yes.
Commonly, generally, the people who come with hepatitis B in the society, it is a self-limited this one, and then
Yeah. A and E are
both-
mostly
yeah.
self-limited.
So at the most, very rarely they can have an acute liver failure, right?
Yes,
Which is a special treatment
Yes,
itself.
and there is. So this is a natural history, which the patient who got infected in the childhood, most of them will have a clearance in the childhood by 20s or 30s, but sometimes they could go to adulthood. Less than 5% of patients will have the hepatitis B, which is chronic, and this chronic finally lead to cirrhosis if untreated.
So that means anybody getting acute hepatitis B, they need not worry, because 95% of the times, it will get resolved, right? It is only the 5% of the people who go into the complication. That means that because of our population, a very populous country, will naturally, this 5% will get it becomes a huge number. But in terms of this one, it is only the 5% that they go into. So one should get reassured that, the moment they get an acute hepatitis B, they should not be thinking about chronicity, and sometimes even they think of even hepatocellular carcinoma. The moment HbS is positive, they say that they will go up to the extent, thanks to the social media and other public places where the information is available. Now the question is to Dr. Mansa. He says that, as I said, you go to the lab and then you get the tested, then HbS is positive, and what is next?
So, first we need to understand what is meant by instantly detected. It is generally when a patient is undergoing a regular health checkup or as a part of some healthcare screening programs, office screening programs. That's when sometimes you can get tested for HbS-Ag positive. Now, as Dr. Shintan elaborated, there are multiple consequences of hepatitis B infection. It can lead to cirrhosis, it can lead to HCC, or it can even have co-infections with other infections. So, and hence, whenever you're detected with hepatitis B infection, it is always essential to further evaluate and consult the doctor and decide if treatment is indicated in this. And what are the tests that needs to be done in the instantly detected group of patients? We need to go for a HBV DNA levels. We also need to get an LFT done to look at ALT levels, especially to see if there is any active inflammation going on, and an ultrasound and a fibroscan. That is, a fibroscan is done to estimate if there is any amount of fibrosis which has already occurred, if there are no other factors secondary to hepatitis B infection. So all these tests are important, and along with it, we also recommend family screening. You should go back and get all your family members, including the siblings, spouse, and children and parents for hepatitis B infection and appropriate treatment as indicated.
So that means you are going to say that, suppose if somebody has got a hepatitis B positive, and then immediately their doctor, they will do the liver function test, of which SGOT, SGPT are the most important things. And suppose if they are high, is this the only reason that hepatitis B is causing the inflammation?
No,
Or any other
it can
reason?
be coexistent with other conditions, even in fatty liver we see, or if there is any concomitant alcohol consumption or any other viral infections. And hence it is very essential that alcohol consumption has to be stopped in these patients.
Okay. Dr. Mithun, Suppose somebody, just now we talked about that the first can happen is an acute hepatitis B. How do we treat them basically?
So when it's acute hepatitis B, the conventional teaching is that you allow the body to fight it out because 95% of them will become negative. So, but there are some criteria where you treat acute hepatitis B. So, if a person is coming with a deep jaundice, which the definition is not sure, but many people consider 5 as a cutoff, and then if there is a worsening of the INR or the sensorium of the patient, which means that if the patient is going into acute liver failure, these are the patients, even in acute hepatitis B, we treat them with drugs. Now, out of these drugs, many of them might become negative at the end of 6 months. Then it's okay, we stop the treatment. But the conventional teaching definitely varies from real life experiences because these are guidelines. So many a time you wait for the patient, don't treat, and they worsen after some time, and it's very difficult to recover. So as a all practical purpose, any icteric flare, because you don't know properly which is acute or which is chronic unless the patient has done an HBsAg before, he was negative 1 year back, now he is positive. Because the core IgM antibody that was shown in the initial slides does not always mean an acute infection. It can sometimes be positive even in reactivation. So we are not always 100% sure whether this is an acute infection or actually we are dealing with a reactivation.
Okay, suppose somebody has got an acute hepatitis, and when do you think, that, they are going into a problem because of acuteness? I'm not talking about a chronicness, acuteness, that is going into very, something like an acute liver failure,
So this
which
is-
requires an immediate attention by the specialist.
So this is common for all the hepatitis, be it hepatitis A, be it E, be it B. Any worsening of INR, lowering of albumin, alteration in the sleep cycle or the mental status, these are the warning signs in patients of any viral hepatitis because it technically means the synthetic function of the liver is not proper. And these patients can go into a liver failure, which by definition is presence of hepatic encephalopathy, that is alteration in the mental status, with a rise in INR of greater than 1.5. So these are the warning signs which we need to keep a lookout in any case of viral hepatitis.
That means if INR is good, done from a reasonably good lab and consistently it is normal, even if slight increase in the bilirubin is there, one should not worry really.
Right.
Right, okay. Dr. Anand, let's come back. We just completed the acute, the consequences. Now we said that, they can go into cirrhosis of liver and the hepatocellular carcinoma. And then Dr. Anand, how do you manage the HBV cirrhosis and chronic liver disease?
I think
Of hepatitis B, related to hepatitis B?
I think it's irrespective of the cause of cirrhosis, the management of cirrhosis remains the same. Only especially for hepatitis B, if the DNA viral load is detectable, then we continue them on tenofovir alafenamide. That there are treatment, there are medicines for this virus. This has to be taken lifelong for patient with cirrhosis, and the recommended dose is tenofovir alafenamide 25 mg, or entecavir is the one other drug which is given at 1 mg if the patient has any signs of decompensation. And also, if patient has other features of cirrhosis like portal hypertension related complications, as shown in this diagram, any ascites, presence of fluid in the tummy, we start them on diuretics. We do endoscopy, evaluate for viruses, we start them on beta blockers to prevent virusal bleeding. We also
what is virus? What is a varices?
Varices are basically enlargement of the veins in the esophagus, food pipe. For that, we do an endoscopy and we screen for them. We evaluate whether the patient has any engorged veins. Then we start them on medicines if at all required. If we don't have any endoscopy, we also do transient elastography or fibroscan, which was suggested. If the values are more than 25, even in the absence of viruses, we may start them on beta blockers.
That means if somebody is HbA1c positive, and then one should get worried if they develop an edema, leg swellings, which is not due to any kidney disease or a heart disease. And also, when they have any black motion for example, or there is any vomiting of the blood. Of course, nowadays we are not going to that extent. The moment the liver disease is suspected because of hepatitis B, or for that matter, as you said, any other cause, we are doing the endoscopy to see that the viruses, as you said, they can have and before that, before they go into complication, can you do anything to these viruses?
We can do banding also. We can do ligation for these viruses if they are very large. If the patient is not tolerating medications for beta blocker, we can also do banding. We also ensure that they should undergo ultrasonography and alpha fetoprotein testing for evaluation for HCC, liver cancer, which is not uncommon, but it is also quite common. If the patient has cirrhosis, very high prevalence, even in the absence of cirrhosis, they may develop liver cancer. That is one specialty about hepatitis B, where it can cause cancer without cirrhosis also.
So how does the ultrasound help in the people with the HbA1c when you are looking after them? This one. You do the ultrasound every time when they come, isn't it? When
every
they come
6
to the
months, we
follow-up.
evaluate for liver cancer. We evaluate for portal vein diameter. We evaluate for there is any enlargement of the spleen, development of portal hypertension features.
And ascites mainly. Ascites, because till some time it develops in ascites, patients may not know that they are developing a water inside their stomach. They think that they are putting on a weight. Many people think that they are putting on weight and they are getting the belly is increasing because of the fat. Actually, it may be because of the water.
But we have been saying cancer and cancer. We should not be should not be apprehensive.
Yeah,
because the risk
that's
of
right.
cancer is hardly 1 to 2% at 5 years. So
Exactly.
more than 80% all hepatitis B, chronic hepatitis B, they don't develop cancer. Not everybody develops cancer.
So I think Dr. Shantanu will tell us, when exactly you suspect that, because now we are entering into, like in any area, we are entering into the preventive. Now the preventive hepatology, preventive cardiology, preventive diabetes, we are entering into the preventive phase, and therefore we have to know, when you can suspect, and then because now decks are different now. Previously, if anybody developed that there is a hepatocellular carcinoma because of hepatitis B, it used to be written off practically. Now it's not like that. We have a survival for 5 years, 6 years, and with the combined treatment. So it is very essential that we should detect it quite early. This one. When can you detect that one?
So as told by Dr. Anand, the apprehension should be less. The suspicion should be high in any patient of hepatitis B patient. So that first we need to identify what are the high risk groups. So high risk groups are all patients with cirrhosis, or in Asian men it was diagnosed, it was told like more than 40 years as a high risk group. Family of HCC, women more than 50 years, the DNA is having high viral load, elevated A level, or a patient having co-infection with other viruses such as HIV and HDV. So this is the population screening of high risk groups for suspicion. Once we do that, what are the clinical clues? So in the clinical clues, we have any unexplained weight loss, any sudden onset pain or right hypercoordinating pain, anorexia or early satiety, patient developing new onset jaundice or new onset decompensation. Decompensation is worsening of liver disease such as development of water in the stomach such as ascites, or having blood vomiting, or having altered sensorium. These are the clinical clues where the patient might be having a progression of disease, hence the development of HCC. So how do you in the laboratory stage, how can you do? You see the alpha fetoprotein, so which more than 8 is enough, but more than 20 is highly significant, and dynamic change of AFP alpha fetoprotein should be seen. Any sudden worsening of liver function test, and having a sudden drop in platelet count. So these are the laboratory signs where you can suspect HCC. And in the imaging, the ultrasound, that is why we do a screening. Any new lesion development, new nodule development within the normal liver, that would be a high suspicion for HCC.
So that means, but unfortunately, many of the patients with the HCC don't have this. They just go for an ultrasound and they find that there is a tumor in this one. But however, I think it all depends upon when you are starting the drugs for the hepatitis B. People have to remember that after the development of a cirrhosis, if hepatitis B is detected, then they have to be on the regular follow-up for hepatocellular carcinoma, isn't it? That is very when you can detect it in very early stage. What is an early stage?
early stage is less than 2 centimeter without any invasion into the blood vessel or any outside spread of the liver disease. So we call it as an early stage. So we have a therapeutic options according to the therapy. So we can completely eradicate the the tumor. We can completely remove the tumor.
Right. And they have to be in the surveillance for hepatocellular HCC in these people. So now that many vaccines are available now for this one, as we're talking about the preventive hepatology. What is a vaccine? Actually, there are different kinds of vaccines are there.
Vaccine is an agent which will, promote active immunity in the person without actually getting infected. So these can be different types of vaccines are there. It can be the inactivated virus or a part of the virus, or like for hepatitis B, the surface antigen. And these are prepared in different ways. Surface antigen vaccine is mostly a recombinant vaccine, where only it is secreted by the yeast cells by the recombinant DNA technology. And we also have that is still in the early stage mRNA vaccine for that one. So basically the vaccine, once you give the vaccine, the person will recognize the agent whenever he is exposed to that again, and then he will develop the immune response like antibodies or the T cells against that, and will fight the infection.
Okay, thank
I
you.
think, sir, one question over here is everybody with hepatitis B, even after getting infected, they think that they should be vaccinated. They ask us the same question every time when they come to our OPD. Should we get vaccine? I got infection. Should I get vaccine? What do you suggest?
I think, you will look for the anti-HBs levels, isn't it?
No, the patient is already infected. HBs is
Right
positive.
now, right. I think there is no indication for the vaccine.
That's what
there.
patients actually have to know, that they
Right,
already
right,
have the
right.
infection.
They think vaccine is the treatment for HBsAg,
That
right?
is not
If
right.
somebody is HBsAg is positive, they should vaccinate their home people, all the contacts,
Yes.
and by telling them. But before taking the vaccine, isn't it important to get tested for the? What do you think, Mithun? Should they get tested for HBsAg?
Yeah,
If so, why?
in the ideal scenario, they should be tested, because
Mm,
many
yes,
of the
right.
times we take vaccine and you don't mount a response, and then you find that many of them are actually positive already. So a positive person will never mount a immune response.
Of course,
So,
this.
but it is not a cost-effective policy
Yeah,
because
that's
of the
right.
mass screening and the
Yes. So in the
cost
camps
effective.
and then other things, it may not be feasible to do the testing. As you said, it is not a cost effective net. But an individual level, it is always better to get it tested, because 7% of our population are positive for HBsAg without knowing that they are positive. And therefore, it is better to get tested and then take a vaccine, right?
And also, I think in healthcare professionals, when they are vaccinated, it is better to look for the response, whether they have responded, developed the antibodies or not, because I think up to 10% are called as non-responders. They never develop antibodies to the vaccine. So sometimes they give, instead of the usual 3 doses, they give for up to 5 doses to see if they develop the antibodies. Otherwise, if such a healthcare professional has a needle stick injury or something like that, then you know that they are non-responders from a positive patient. Then you have to give the immunoglobulin to those personnel. So it is important, at least in healthcare personnel, to know the whether they are responders or not. Yeah.
Absolutely. And one more question everybody asks is, if my blood touches your blood, what is the risk of transmission? What is the percentage of chance that I will get infected?
Touches.
Yeah.
With touch, it is, I can't tell you the percentage, but needle stick injury, again in that with the needle size, the hollow bore and all those are important. And again, mucous membranes, that is there. But just the cutaneous exposure, it doesn't.
It never
yeah.
happens. That's
Never
the
happens.
major
Yeah.
problem, I think.
But the main message should be the amount of blood required to transmit hepatitis B is much less than that required to transmit HIV.
HIV or HCV, yes.
So, but people don't, because HIV is a more dreaded disease, the government there's a lot of campaign on HIV, but as Hep B kills possibly more patients now than HIV.
Yeah, the hepatitis B, I think the rate of transmission is 30%.
Right.
Yeah.
If you have a needle stick injury, yes. yeah,
Not
yeah.
only that, many people come to us and tell us, because it's there in the Google and then everywhere, that it is secreted in the sweat also, right, But there has to be a break anywhere, either in the mucosa or in the skin, for the tiny, this 40 nm virus to go inside, And just because somebody is secreted in the sweat. And what about milk? Because HbS is positive, mother gets pregnant.
Breastfeeding is safe in patients.
Safe
with
in
HIV.
yes, correct. So that just because HbS is a positive, they should not stop breastfeeding, right? And Dr. Sadhana has talked about 3 injections, 5 injections. What do you think, Vipin? What is the conventional advice which are given? In which group you give it more number?
So conventionally 0, 1 and 6.
What does it mean? 0, 1, 6?
First dose at 0 month,
Right.
second dose at 1 month, third dose at 6 months. But suppose we are dealing with an immunocompromised patient, like a patient with a chronic kidney disease, then there are recommendation of additional dose. Again, additional dose are recommended in patients who are non-responders. But when we are dealing with a non-responder, the first step is to find out if they are HBsAg positive, because that is the most common reason. And another method is that once as a healthcare professional, if I have mounted an immune response, now many centers, they keep on doing anti-HBs as a routine test in the annual health checkup for the employees, and they start giving booster doses. So this is something which is
Not?
is not
Necessary,
recommended,
not
which is not
necessary, yeah.
recommended.
Yes.
And this needs to be, this is very common in all settings. We see your antibody is low, take a booster. If necessary, take a full vaccination, not a booster.
And then another common question which the people ask is that, I ask them, have you taken a vaccine? So I do not know, I must have taken 1 dose or 2 doses, I do not know.
I tell
What-
them
what
to
should we- What should
revaccinate.
we do?
I tell them if you've forgotten, revaccinate.
Right. Do you tell them to get the tested for
But antibody, if
anti-HBs?
it is high, it's yes.
Right,
If
right,
you're dealing with
probably. Because they don't even know, they must have taken all the 3 also.
yeah, they must have taken all
So
the
best thing is to get tested for anti-HBs. If it is less
Low,
than 10,
10.
basically, they should revaccinate all the 3.
yeah,
years.
all the 3.
And another is, as I said, booster is another common thing which they
Yeah.
ask, do you have to
Actually,
take a booster, So it's not necessary to take a booster, this one.
That's
right?
not in the guidelines. That's in HR policies of many hospitals.
They also say that, even if it is a little less than 10 MIU also, when you, are exposed to the virus, that itself will act as the activate and you will develop antibodies. So the immunity is, for a long time. That is what they say.
And when we are on vaccination, it's also probably recommended that cirrhosis, if it is the cause is not because of hepatitis B, it is suggested that they should also get vaccinated for hepatitis B.
Yes, that is because if for any other reason, if a liver disease is there, maybe alcohol, maybe the so-called
NASH.
non-alcoholic fatty liver disease, then they are still prone for hepatitis B infection, and therefore, of course, routinely people test when they go to the hospital, they test HbSAg. If it's negative, and then they should get vaccination, this particular group also, isn't it? Because it is quite, if not dangerous, is quite significantly important, that they should not get an acute hepatitis B infection over an already existing chronic infection because of some other reason. Right?
Yeah, we also have combination vaccines with hepatitis B and hepatitis A. With the high prevalence of hepatitis A, even hepatitis A vaccines are recommended in order to prevent acute liver injuries,
Oh, yes,
especially in certain subgroup of patients with high risk.
Now that you have touched upon the twin, what do you think is happening to hepatitis A nowadays as compared to the previous days?
As compared to previous days, earlier majority of the population were immunized to hepatitis A, but now
By natural infection.
natural infection.
Not by the vaccine.
Yes.
By-
Now, over the years, there's probably a change in the virus and the antigenic profile, and we are seeing a lot of cases every year, particularly around the monsoons, who come with varied courses of hepatitis A
Adolescents and then adults.
and adults, and immunocompromised patients who present with severe jaundice, which prolongs for a prolonged period, cholestasis, itching, and also some cases with severely acute liver failure needing liver transplantation within 1 to 2 days.
So that's
And-
what is we called it a hygiene hypothesis. That means the more amount of hygiene is improving, some of the infective diseases like hepatitis E, which they did not get when they were young and then children, they get it in the adult and adolescence and then adulthood. Like any disease, anything, any infective problem, if it comes in an adolescent and adults, is going to be severe. That's the reason why we are nowadays we are seeing hepatitis A a little bit more severe than the usual which we are accustomed to see. Oh, Dr.
So
Mithun.
any particular vaccine you would recommend inactivated vaccines in patients of cirrhosis? Because we are talking about a cirrhotic patient is an immune compromised patient. So
I think right now we are having only this
because
recombinant.
hepatitis A, I presume there are two types of vaccines available now, live and dead. So what would be our preference? Anybody has any
The
comments on that?
Inactivated vaccines in a
In a
cirrhotic
cirrhotic
patient.
patient.
In an immunocompromised, you generally give inactivated vaccines. Yeah.
Yeah, and this hepatitis A thing, it was very, we tested around close to 1,000 samples of HAV IgG to see, and we could not find a single patient who had negative antibodies. But yet adults keep on getting hepatitis A. So whether there is a different strain or a different genotype, we don't know.
Or are they not protective, those antibodies?
But the real scary thing is about hepatitis A is we are seeing a lot of acute liver failures, especially in the young adolescents. That is where hygiene hypothesis is probably working. The population which we may have tested is patients who had 50 years or 55 years, who are like us and who are probably protected or got infected when they are young. That is where we are missing probably. But
So-
vaccination is must for hepatitis A for younger adults also. I also got tested and I am protected.
Because it's not a part of national immunization schedule as of now, hepatitis A vaccination. And hence we recommend all adolescents and high-risk groups to take hepatitis A vaccination.
Okay, I think we have covered quite a bit in this one. We told the importance of today's importance like a World Hepatitis Day. We talked about the hepatitis B, and I think basically we should get reassured that number one, acute hepatitis B, even if somebody is jaundiced with even very high levels of a bilirubin, they need not get worried because by 95% of them they get better, right? And we also discussed about the warning signs, this when they have to worry about acute hepatitis. So that means that you don't have to worry about hepatitis B, right? Acute hepatitis B. Then coming to the chronicity, as Dr. Mansa has said that many of them are incidentally detected. They just go for hepatitis B and then it is tested. And this hepatitis B testing, they can be in any stage actually. Hepatitis B is only a testing process. They could be having a chronic liver disease without knowing that they are having a liver disease. As rightly said, immediately we go for an ultrasound and then liver function test. And we have a drugs, isn't it, Dr. Shantan? We have some very, very potent drugs to suppress the hepatitis B infection.
Yes, we have few drugs. Currently, the drugs which are approved are basically to decrease the viral load, but there are no currently which are approved drugs which can completely make the virus negative. So, slide please. So currently, from almost long term ago, it was the antivirals which are directly acting antivirals which are used. So whom and how to treat the drug treatment, basically the decision will be based upon three main important parameters which are ALT, the allele aminotransferases. Nowadays the newer cutoffs have come into picture. Before it was made as 40, now it is for a male it is even 30 and female 19. Above that is also considered significant. Any DNA levels which are more than 2000, a patient having an higher fibrosis of the liver disease, and patient who are initially suspicion of any for chemotherapy or they are planned for chemotherapy also should be the subject who should be planned for treatment. So from drug treatment started from 1991, now currently in 2016 with the introduction of tenofovir alafenamide, a much refined molecule of tenofovir. So there are, in short, there are two groups which are drugs with low barrier of resistance. They are the old groups where it is better to avoid those drugs because there are high chance of drug resistance. So drugs with higher barrier of resistance, namely the entecavir, then you have tenofovir, one molecule, and tenofovir alafenamide, the second molecule, the refined molecule. So these are the drugs which are currently being used for patients with hepatitis B. But how to choose? So if any no comorbidities, we have even any monotherapy with entecavir, 0.5 mg once daily and 1 mg for cirrhosis. TDF or TAF can be used. But even any patient with old age, having bone disease or the renal abnormalities, it's better to avoid TDF. So you need to prioritize entecavir or TAF. So how do you differentiate TAF or entecavir? It's based upon previous exposure to other molecules and renal dysfunction. So all have the almost more than 90 to 95% success rate of declining the viral load. So and these are the drugs which are currently being used.
So that means you got, in summary, you got a very effective drugs. Isn't
yes,
it?
yes.
Right? Very effective drugs for suppressing the
Virus load.
but
Yeah.
not for eliminating
Elimination
the
the virus.
HbA1c status,
Yes.
right? That means people think that's the reason why the treatment is a prolonged, if not a lifelong treatment. So Dr. Anand, HbA1c doesn't exist alone, isn't it? They take alcohol, they are obese people, they have got a diabetic people. What is the influence of this on the course of the untreated hepatitis B?
I think it rapidly progresses. Progression to cirrhosis is very high, 2 to 3 times higher in patients who consume alcohol, and it is recommended they should strictly abstain from alcohol. Obesity is also a deadly combination, so they have to manage their weight, they have to cut down their weight. Third thing, hepatitis D, which WHO now recommends that every hepatitis B should be recommended for hepatitis D, that is Delta. We have found that very few patients in our population actually positive. Hardly 1 to 2 patients were found positive out of 150 patients which we assessed. But if it is there, it has again higher risk of progression to cirrhosis and liver cancer.
I think we have talked enough of the hepatitis B. I think summarizing that we don't have to worry about hepatitis B.
Absolutely.
A, because acute hepatitis B, as we already said, 95% of them they recover, and rest of the thing also we can treat them provided we take the warning signs of what is going to happen to that one. And chronic hepatitis, again, even if cirrhosis is there, you don't have to worry because we got a very powerful drugs are there. Only issue is that patients have to be very compliant. They should not stop taking the drug just because they don't have any symptoms. They must continue to take and stop it only when they have been advised to stop. That is another thing, because the cost is involved in this one, right? Fortunately, some people are getting free of cost, some with the governmental support. Third thing is, when after the developing the liver disease also, these drugs are very effective in controlling at that particular stage. And also we said that to prevent or to detect early any kind of a hepatocellular carcinoma, we got an effective means of just simply, we don't require anything, we just have an ultrasound to be done every 6 months, and then a simple test like an alpha feta protein has to be done. With these things we are able to detect very, very early malignancy, cancer in these people, so one need not worry about it. Then lastly, even if hepatocellular carcinoma is developed also, we have got a very, very, very effective means of controlling, if not completely treating, and prolong the life stay of the patient to be able for going for a liver transplant. That is again important that, so that when do you place for a liver transplant in these people? What are the situations when they require? That is again commonly asked in every liver disease.
Patient has advanced liver disease, if the patient develops jaundice as decompensations like ascites, water in the tummy, or developing recurrent bleeds, then or developing a liver cancer in the early stages, we can offer them transplant.
Okay, I think we'll stop here. Thank you very much, all of you individually. And yes, please go
just
ahead.
one point. I think for the general public, it is very important that they get their HbA1c status checked at least once, and if they are found negative, they should take the vaccine, because the vaccine is very effective
Right.
in preventing the disease. That's
Okay,
what.
that's a good message, that please get tested, that's what. If you don't get tested, we will never know about it. Go get tested, and then if negative, take the vaccine,
Vaccine.
right? If you're positive, don't worry about it, right? Still, you got, there are lot many things
Yeah,
which you
still there's
discussed,
hope.
how why it can be, we can prevent, and then we can treat, and hold on at that particular stage.
Yeah, so one more thing, one more social stigma is that if I get diagnosed with hepatitis B, can I get married? Will that affect our future generations?
You are asking me, or you, are
No,
you
that
will
is the
answer me,
social-
you will answer, right?
So currently the social stigma is not that should be removed. So any patient with hepatitis B, any person with hepatitis B, it's not a patient, it's a person with hepatitis B, can get married, but the partner should be vaccinated so that the horizontal transmission will not be there, and hence the future generations will not be affected. And so that stigma should be removed, and everyone should be encouraged for testing and vaccination.
Okay, thank you very much. I think Dr. Mithun, thank you, Dr. Anand Kulkarni, Dr. Shantan, Dr. Mansa, and Dr. Sadhana, thank you very much for all of you. I think if there are any questions or anything, they can be clarified, Thank you.